All right. Welcome back to another episode of ICU Doc Talk. I have not recorded an episode in months, uh, but here I am. And number one, I apologize, but thank you for joining me again today. And I hope to explain myself. Actually, I don't have to explain myself. I have no excuse. I just. Anyway, well, I'll back it up. So this is a podcast that I usually do. I'm a anesthesiologist, critical care physician. I work in critical care at a major academic center. This is a podcast where I talk about medicine, and then I also talk a lot about books, a lot about nonfiction books and fiction. I talk some about politics, economics, whatever, just lots of stuff. It's kind of just stuff from my brain. So here I am. I'm back, and it's been so long since I've done this. I kind of forgot even the format of this show, if I even really had one. But anyway, I just kind of, you get busy, you got other stuff to do, and it became less of a priority. And I apologize for that. It should be a priority. I know people listen to the show and they like it, and I get many lovely and great emails from lots of people. And lately, people emailing me and be like, "Where are you? What are you doing?" So I've seen emails, and I appreciate it. And nothing has happened. I'm fine. I'm doing great. Actually, I had another child. I should say that. Nothing happened. I just don't get very personal on this show. I don't like to share a lot of personal information. I'm very private about my personal life. But I had another child, and my family's great. My wife and children are doing really amazing. You know what though? My cat died. Yeah, my sweet little cat, little Junebug. If For people that followed me on social media, which I stopped doing over a year ago, I used to make posts about my cat. It was this tuxedo cat named June. She was 17, and she passed away, and it was really hard. It was, of course, very hard for everybody that has pets. Pets are an animal, or they're part of your family. And the thing that's hard about losing a pet is that pets aren't complicated. They're nothing but love. They're not messy, complex relationships with humans. So when you lose one, it's just a gaping hole, that's just left behind. She was, oh man, I'm choking up just thinking about her. She was the cat that she was my wife's cat when I first met my wife, 15 years ago. And she went with us to all the cities that we moved through, and she had such an amazing long life, and healthy except until the end. She had kidney disease, which usually takes little kitties. And you know what? We knew she was kind of going downhill. Her kidneys were failing her. She stopped eating, and I knew the time was coming. And at 4 a.m., my wife woke me up, and she was like, "Something is wrong." And I went to this honestly has a lot to do with medicine and critical care. It's knowing the right time for a big part of my job is helping people pass away appropriately and minimizing suffering and minimizing trauma for family members. And I went to June, and I saw she was making, just basically agonal breathing. Clearly something was wrong. I knew she was dying. I told my wife she is dying, and so my priority was I rushed her to a vet for euthanasia at 4 a.m. I called work. I said, "I'm not coming in," and I work in an amazing place with amazing colleagues, and they were like, "You got it. It's fine." I told them why, and they were like, "No worries." And someone covered me immediately. This is 4 a.m., right? I had to be in surgery in 3 hours. So I work in an amazing place. Truly amazing people. And then I took June in the car. I was petting her. I was telling her how much I loved her, how much we loved her, and she was very uncomfortable. And she passed on the way there, just as I was petting her. And it was really hard. So, anyway. But anyway, I think I used to start this podcast talking about, what did I call it? Something from the void? Hot takes from the void. Like the hot takes from news headlines and stuff like that. I don't really want to do that anymore. I think it's just kind of dumb. If I talk about politics and stuff, it's usually associated with books, and I'll do it at the end of the show. I don't think people tune into this podcast for my political takes. So, although I think anybody should feel free to share their political takes at any time and in any space, right? You know the sort of it, right? I hate Trump, etc., fascism. It's all, you know it. So maybe I'll read some. I got some great books to go over at the end of this to talk about, and I'll get into that stuff if you care. But I don't think I'll do the politics stuff up front at the beginning of the podcast. I don't think it's. I don't know. I just don't think you really care a whole lot. Okay, so what am I going to talk about today? Let me see. Okay, let me go through some emails. There was an email, okay, here's an email from Julian, last name withheld. Podcast topic suggestions. Okay, I'm a night shift new graduate nurse working in med-surg level 3 ICU. I recently participated in a code involving a post-CABG. CABG is a coronary artery bypass graft. It's a bypass, heart bypass, on an intra-aortic balloon pump. So it was a code involving a post-CABG on balloon pump with severe pulmonary hypertension. And I realized how different it felt to a standard code blue. Absolutely. I was wondering if you might consider discussing scenarios or variables that change your approach when running a code on a post-operative cardiac patient, such as indications for or against performing a bedside sternotomy, and other nuances that make these situations unique. Also, I really enjoy your podcast. I've listened to almost all the episodes, and I hope you continue releasing more. All right, this is a great topic. This is definitely what we're going to talk about today. This is like my wheelhouse. This is what I do. I work in a cardiosurgical ICU. I work with ECMO. I work with mechanical devices and post-CABG patients, post-cardiotomy patients. So this is a great topic. Thank you, Julian. Let's do it. And then I'll get to some books at the end here. Oh, and I forgot. I got some big news about because I'm an author. I write sci-fi. I got some big news about some of my books, which I'll share at the end here. All right, let's jump into this topic. Okay, so getting to the heart of this question. So we're talking about code blue in the United States. That's cardiac arrest. So the ACLS algorithm in the United States. That's the algorithm we use when someone's in code blue. All right, you can go look it up, but if you're not familiar, but there's a protocolized way of when someone has cardiac arrest, you initiate a code blue and you go through this protocol to try to resuscitate a patient, right? That's standardized across the United States in medicine, right? You do chest compression, you do your pulse checks every 2 minutes. You give epi every 2 to 3 minutes. There is an algorithm, and it's a good algorithm. It's great. It works well. It's pretty simple. And it's to resuscitate someone and to get them out of cardiac arrest. And I've done it many, hundreds of times, more than that. And it's great. So the meat of this question is we're talking about a very, very, very specific patient population, patients that have had heart surgery. And then they come to the cardiac ICU. So heart surgery is very dangerous. That goes without saying. Now, people are nervous before surgery. People will be nervous before a sinus surgery, right? Something that is very routine. And it's your right to be nervous before surgery. I personally wouldn't be nervous before surgery, except heart surgery. I would be nervous before heart surgery. Doesn't mean anything's going to go wrong, but heart surgery is dangerous, more than average other surgeries. Maybe not more. I don't know the stats of that exactly, but there's just a lot going on, and things can go wrong. It's still generally safe, and if you need a heart valve replaced or whatever it is, please pursue that. Don't want to scare you. But patients after heart surgery that go into cardiac arrest, they have very specific reasons to be in cardiac arrest. What you don't, a code blue is handled very differently from a standard ACLS arrest. And the priority is basically protecting the surgical repair that's been done, right? Okay. And avoiding sternal damage with chest compressions. And then you got to rapidly identify the reversible cause. And what is it about the specific surgery that has probably gone wrong? And that often, if someone's in cardiac arrest like that, sometimes it requires immediate internal cardiac massage rather than like a prolonged chest compressions. So basically, you don't want to just dumbly start a code blue and start doing chest compressions on a patient like this. That's the wrong thing to do. That's wrong. Not only is that like, you should not be doing that. That's wrong. You should not get on someone's chest, okay? Because you can destroy their heart. There's sternal wires. There's new valves. There's things going on. There might be the devices in there. Maybe there's an impella sitting in their heart, right? You do not want to start chest compressions on a patient like that. You can kill them. Someone that goes into cardiac arrest after heart surgery, they have a very good chance of coming out of that arrest because there's oftentimes an immediate and reversible cause. And sometimes it requires opening that chest up and, yeah, doing cardiac massage. I've done that before. Sometimes you just got to do it. Okay, so you need to be very aware of these things. If you're a critical care nurse and you work in a cardiac ICU, obviously you're going to get oriented to these things and understand these things. So the core principles are external chest compressions are a last resort and often entirely avoided. You can disrupt sternal wires, like I said. You can cause anastomotic ruptures, right? Grafts that are put in there, you can blow them out, which patient's dead. Like, say someone's bleeding a little. Say someone has a bovine patch somewhere. They're ascending aorta or something, and say that's ruptured or that's bled a little bit. Let's say they go into arrest because that's dehyst and a little bit, and it's causing tamponade around the heart. Okay, that's a scenario, right? I've seen that. And that tamponade is like a vice on the heart, and that's why they've arrested. What's the right thing to do? Open the chest up, relieve the blood, and have a surgeon there to patch it. That probably requires ECMO. That a patient like that either needs to be opened up immediately in the cardiac ICU or emergently rushed to the operating room and go on cardiopulmonary bypass if you have time. If you don't have time, if they're dying, you got to open their chest right there, try a cardiac massage, volume blood resuscitation, and the surgeon needs to run as fast as they can, whether it's a fellow or it's the attending, whoever is available, to come and repair that. That's the correct thing to do in that situation. Okay. Now, if you were to start chest compressions, well, maybe you're going to cause that graft to blow out even more. Now they're really dead, and maybe you've destroyed any chance of that graft being repaired. And now that's a problem. But most arrests in these patients, they're PEA arrests, pulseless electrical activity, and they're due to surgical or mechanical issues. They're not. They can be, they can be arrhythmias and heart attacks and stuff like that, but less common. If you have no pulse within 10 to 15 seconds, you have to be prepared to reopen the chest at bedside. You have to. That's why you have to have an experienced team there, the sternotomy kit. And when you got to make that call, you got to make that call. You cannot delay. So if I have one of my patients, right, this is where I usually work. If I have a patient, I see they're in cardiac arrest or fresh post-op, and it's not like VTAC, right? If it's VTAC, whatever, it's fine. You shock their chest, you go through the VTAC algorithm, give them antiarrhythmics, you get them out of it, that's fine. But if they're just pulseless, right, they just don't have a pulse, they're dead, like they're just in arrest, and there's sinus tach or something, my first thing is I look at what's going on with the chest tubes, because if those chest tubes are full of blood, they're bleeding, and that's a surgical emergency. It needs to be repaired right there, right then and there. And so the next thing you're basically doing is getting a sternotomy tray to open the chest. Now, I don't want to, as the intensivist, I don't want to be doing that. I shouldn't. I'm not a surgeon. But if there's no one there, if the surgeons aren't available or they're not present, because they're often not, they're doing surgery or whatever, you might have to do that. That's why I've done cardiac massage before. I don't want to, but if you have to do it, you have to do it. So anyway, you have to be prepared to open the chest if you work in a unit like this. So the causes of, let's just run through the causes of arrest in immediate post-cardiotomy patients, okay? Here's just a rundown of reversible causes in the treatment, okay? Cardiac tamponade, very common. That's my mind goes there immediately. If a sudden hypotension, PA arrest, what's the treatment? Open the chest, evacuate clot, and look for bleeding. One thing that may be unappreciated in tamponade, when you think about cardiac tamponade, you often imagine the sac, the pericardium, or the area around the heart is just full of blood. But it might not be full of blood. There might be a clot, just a single clot, like a little slow bleed at the back of the heart, and then it's just slowly bleeding, clotting, and it's just a clot and it's enlarging, and it's just pressing on one chamber. So you might do a quick TEE or a TTE, a surface probe of the heart, and you look and you're like, I don't really see tamponade. I don't really see tamponade physiology. I'm not seeing diastolic collapse of this chamber. Well, if you don't get a 4-chamber view, and if you're not doing a TEE, a transesophageal, you definitely can miss a clot sitting there. I've seen that many times. I'll do an exam myself, an ultrasound exam. Like, I don't really see tamponade, but it's acting like tamponade. And I'll talk to the surgeon. I'm like, this is acting like it. And oftentimes surgeons will be like, all right, I'm going to go down the OR and take the patient down the OR. And sure enough, there's a big clot sitting on, the RA or whatever it is. Happens all the time. It's really common. Okay. We've already kind of talked about it, but another cause is graft or cannulation complications, like a graft occlusion. like someone has a cabbage, right? Coronary artery bypass graft, and a graft goes down. It thromboses, and they have VFib arrest. You can have bleeding of the suture lines. The treatment there, if you're having bleeding of the suture lines, yeah, you might reopen the chest as well. Just hypovolemia, underfilling of the heart, that can be due to bleeding. Vasoplegia, where your vasculature just doesn't have good tone anymore. Cardiopulmonary bypass and fluids and a bunch of adrenergic activation, that can cause vasoplegia. And then arrhythmias, right, which we've already talked about, VFib, VTAC. You just defibrillate immediately. You put pads on the chest, defibrillate. You go down your algorithm for VTAC or VFib. If it's VTAC or VFib, another thing, you're always thinking, what is the surgery that was done on this patient, right? There's lots of different types of cardiac surgeries. And so if you're in the intensivist or the nurse or whatever, or the NP or the PA, you have to know what you got to keep in the back of your mind, what was done to this patient's heart, and what could go wrong, or you got to think of like, what are the mechanical reasons from that surgery that could have caused this arrest. So you have to be thinking of those things. That's why you need to know the specifics of the surgery, right? And then you can just have RV failure is a common one. That's a little more. Some of these common symptoms, causes of cardiac arrest can be a little more smoldering, not so acute. If someone's in RV failure, that's usually like a smoldering issue. You kind of see it coming. Their cardiac indices are going down. Their urine output's going down. You look at their heart, their RV's crap. So you can kind of see that coming along as they're slowly going into cardiogenic shock. So let's just go step-by-step approach to a cardiac arrest post-sternotomy. Okay, patient arrests. Okay, you call a code blue. You announced post-op cardiac surgeon. This is a cardiac surgery patient. Everybody knows that. They should. And that triggers the cardiac surgery arrest protocol. Your institution probably has a different protocol. Mine has one. We have a specific name for it, and it triggers that. Okay, and the need for a surgeon. Surgeon needs to come. You do a quick assessment, 10 seconds. Is there a pulse? What's up with the airway? Is there a pacing issue? Do they have pacing dependency? Do they have heart block? Verify your lines. Look at the chest tubes. Very important. Lots of blood means something. No blood also means something, because if you have no blood coming out of the chest, right? Everybody should have after heart surgery, has a little bit of blood draining from their mediastinal or pleural tubes. You need a little bit of chest tube output. But if the nurse is like, you know what, I've gotten no chest tube output for the last hour, and this is a patient who's post-op, 2 hours post-op, they're clotting, right? And they could have a clot tamponade. So that's useful information. Inspect any mediastinal drainage output, like I said. Make sure they have good oxygen delivery. If they're being paced, which they should be, they often have epicardial wires. Turn the tent pacing up, right? Just jack it up to like 20 milliamps and a rate of 90 or 100. Check their pacing. This is a good story. I had a patient who was doing really poorly, really, really bad, just smoldering all day after heart surgery. And they were so bad that I just had a transesophageal probe in their esophagus all day just to watch their heart. I'm forgetting the specifics. This was a couple years ago. But so I'm watching their myocardium on basically real time, looking at their heart pump. And we were discussing putting this patient on ECMO and stuff. And I had a couple surgical colleagues around. We're talking. And as we're standing there, I'm watching the patient's heart. And it just happens to go into rest. Like, I literally see it in real time on the echo machine. And I'm like, oh man, cardiac arrest. And then I'm basically like, sternotomy, let's open the chest up. Do it. And everybody starts mobilizing. But then one of my surgical colleagues, who I really admire, great guy, really, really, he's such a great surgeon, heart surgeon to work with. He's like, hang on, hold up. And he went to the epicardial pacing and he jacked up, he went to V pacing and he put the milliamps at 20. And then we got captured and the heart was beating again. What happened? The patient went into heart block, right? And I knee-jerk reacted. I was like, sternotomy. But he was like, hang on. So another surgeon was on board with opening his chest up. But this other surgeon was like, hang on. And I was like, whew, at least we didn't, we would open that patient's chest for no reason. So that was a nice save, just a nice reminder. I was like, oh yeah, duh. Like, make sure your pacing's up. Okay, so if it's PEA arrest, you do not start chest compressions. Instead, you call for a sternotomy tray, open chest now, whatever it is at your institution. Most centers use a rule. If there's no pulse after 10 to 15 seconds, open the sternum. Maybe if most centers, some do, some don't. And the reason is because most recoverable causes like tamponade or a graft kink or surgical bleed or artery failure are only fixable with that direct cardiac access, right? That's the reason. So if you're going to open a chest, it's got to be a CT surgeon or a trained ICU team, right? If the surgeon's not there yet, and it has to happen, then you got to do it. Now you got to understand, like, you have to know what you're doing, right? If you open up a chest and you don't know what you're doing, like what I mean by what you're doing, like, do you have the experience to do this? Are you confident? Do you know you need to do this? Like, you got to have experience before you're making this decision, right? So, but or else your surgical colleagues are, if you did it and it was inappropriate, you're gonna have problems. your surgeon's gonna be like, what are you doing? What the hell did you just do? So you gotta know what you're doing. I'll just say that. You remove the jetchings. Maybe you cut the sternal wires. Of course you cut the sternal wires. I was thinking epicardial wires. You open the sternum using sterile technique. If there's clots, evacuated. Internal cardiac massage if it's needed. If they don't have a pulse, you got to give it to them. How do you give it to them? You pump their heart with your hand. Okay. Maybe they need internal defib pads if they're available. Identify bleeding source. Do they need to go to the OR for bypass? Or do they need ECMO right now, centrally cannulated? These steps I'm talking about are a surgeon should be doing all of these things, all of them. But oftentimes, opening the sternum and doing cardiac massage, sometimes the ICU team needs to do that to save the patient's life, to preserve their brain function and their organ function. Okay. And then rhythm-specific things, right? VFib, VTAC, you shock them. External pads, put them on, shock. Okay. Again, asystole, think tamponade, hypovolemia, pacing failure. Do you need inotropy, fluids, blood? Do you need urgent chest opening? Do they have severe bradycardia? Do they have heart block? Extremely common. Use your epicardial wires. I can't tell you how many times you see this, heart block and severe bradycardia, and I have to go up on the epicardial wires. Very, 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 very common. Something you really need to keep in mind. Epinephrine's an awesome drug. Okay, use it, and you don't need to slam them with a code dose of a milligram. Maybe that you know what? I'm just going to get this patient floating with 200 mics of epinephrine. Okay, really, really important. Don't slam somebody if they're not really in cardiac arrest. And sometimes you know the patients and you know this nuance so well that you're standing there and you see they start to go pulseless. But because you know what you're doing and your experience, you can be like, I'm just going to give 500 mics. I don't want to slam them. I don't want to give them a bunch of afterload. You're allowed, if you have the experience and you're allowed that latitude. You don't have to think so protocolized. Don't get me wrong, protocols are good. But you don't have to be so protocolized if you understand the situation, if you have awareness of the situation. Okay? Calcium, bicarb, vasopressors, all of that. Okay? Okay, so just to summarize the differences between standard ACLS and this post-cardiotomy protocol. Chest compressions, you do them in ACLS. With cardiac surgery, they're delayed or you reopen the chest. Primary causes in ACLS are usually like an arrhythmia or an MI or a lot of other things. In a post-cardiotomy, they're usually tamponade, bleeding, graft failure, like we talked about, pacing failure. ACLS, defibrillate, you do it standard. Post-op, you can do it external or internal if you have an open chest. Standard ACLS, you give epinephrine, you give it early, you give full dose, minimize it in post-cardiotomy, right? Maybe they only need 200 mics or 300 mics or whatever. And then with post-cardiotomy, open the chest. Think about it. You often need direct cardiac repair. It's one of the main fixes of it. Now, what about if someone's on ECMO and they have what is arrest? What is cardiac arrest on ECMO? Because if you're on VA ECMO, right, you literally could, you get patients on VA ECMO. The heart is already not moving. They're already arrested. So what is a code? What does the equivalent of a code look like on someone on ECMO? Well, that's a big topic, and it's kind of a topic for another day. But because you're obviously not going to do these things if someone's on ECMO because you're already perfusing their body, right? You don't do cardiac massage. You don't do these things. Other things are going wrong on ECMO. Maybe you're having suck downs, or you're bleeding, or like tons of things go wrong in ECMO. Do not get me wrong. But it's a little bit different. If someone's in arrhythmia, they're in VTAC, What do? Well, you got to get them out of VTAC, right? Why? Why do you have to get someone out of VTAC on ECMO? Someone could be like, well, what does it matter? If the VTAC is not perfusing their body, they're already on ECMO. Well, if you have VTAC, you're having low flow through your ventricles and your aorta. You can clot off your chambers, which of course is bad. Could prove very fatal for the patient. And also you're straining the myocardium. If the myocardium is moving, if it is actually moving, that's way too stressful for your myocardium, right? Your oxygenation is very poor, and your perfusion of your actual muscle tissue, your heart muscle tissue, is poor, right? But anyway, that's a whole other topic. But but more of the broader scope is mechanical devices. So resuscitating a patient who does have a mechanical device, meaning like an aortic balloon pump or an Impella, or maybe they have an LVAD, or maybe they're on ECMO. These things also go into your resuscitation of the patient. One kind of point I want to make is a very specific point. Basically the only device, the resuscitative device for a patient, is ECMO. You don't want to put in an Impella CP in someone who has active cardiac arrest, in my opinion. Even when they're on the cath lab table with cardiology and they have a Lucas device on, they're getting chest compressions, and because they have a STEMI, right? They have a heart attack. A patient like that, in active cardiac arrest, to put an Impella CP, which is an Impella is a little snake pump that gets snaked up through usually your femoral arteries, and it gets deployed in your left ventricle. An Impella doesn't generate enough flow for resuscitation. It's usually capped at like 3.5 liters of flow, right? An Impella 5.5, which is usually placed to the axillary artery, you get flow of 5.5. An ECMO machine, you get even more flow, right? Because you put these big cannulas in. You put in these big 25 French, 18 French, whatever cannulas in, you get plenty of flow. You can get flow up to 6 sometimes, usually not above 6. Anyway, my point is I've just seen this where trying to put in an Impella CP in a patient like that will not resuscitate them. And an ECMO, VA ECMO, is the only mechanical device that's resuscitative in an emergency, in my opinion. Willing to be challenged on that, but I don't know. I've seen it enough times that you got to make a decision to put someone in ECMO. But you also have to know, like, hey, maybe these someone could be kind of peri-arresting in this patient population, and they're not doing well, and you're struggling all day. Sometimes you just got to bite the bullet and be like, this patient needs more flow to their body. Their native heart is not doing enough. The Impella CP they're on, their balloon pump is not doing enough. We need more serious mechanical augmentation for this patient. And if you're struggling, the lactate's climbing because you're not perfusing, pushing all their organs into anaerobic metabolism, and their urine output is getting terrible on all these things, and their digits are looking, worse. You got to be like, we need to escalate our mechanical support for this patient. This balloon pump is not enough. Balloon pump, so balloon pumps are great, right? For those who are not familiar, balloon pump is it's a balloon. It's a long balloon, elongated balloon that's placed up through your femoral artery, placed into your descending aorta, and it inflates during, think about it, when would you want a balloon in your aorta to inflate? Not during systole, right? Because you're blocking the flow of the heart. So it inflates during diastole. That helps with coronary perfusion, and then it deflates during systole, and that deflation creates kind of a suction effect, a counter pulsation effect that also augments your cardiac output modestly, right? But so balloon pumps are fine, they're great, but sometimes they suck, and you get to a point where you're like, this balloon pump is not doing anything, and it's becoming a liability for this patient. It's not augmenting their flow enough, and it causes it threatens the viscera. It can cause malperfusion of your gut. It can. I've seen it enough times to be very wary of balloon pumps long term. I've seen people die from malperfusion of the gut just from the balloon pump. Absolutely. So you got to make it, if things are not heading in a good direction, you got someone on a balloon pump. Say you have a patient who's had a heart attack, they got a cabbage. So let's say they got a heart attack. They had a heart attack, and they went to the cardiac medical ICU, and they got kind of optimized there, and they finally consulted with a surgeon, and they took a surgeon took the patient down to get a cabbage, and they were put on a balloon pump pre-op, okay, and now they come to the cardiosurgical ICU, and they still have that balloon pump from before, which is a good idea, and now they have a cabbage, so they have coronary bypass grafts, and maybe their EF is like 35%. Well, let's say that patient is now climbing, they're on 0.02 mics per kg, or let's say 0.1 mics per kg per minute of epinephrine. They're on norepinephrine. Their RV's not doing that hot. And their lactate's climbing. And that's the situation I'm talking about, where you gotta we gotta change the paradigm for this patient. We need to escalate care or they're gonna die, right? I had something else to say, but I forgot. All right. Anyway, I think that's it. That's all the time I have to talk about medicine stuff. So let's see. What do we usually do? Hang on, I forgot. Okay, I'm truly the worst podcaster. I am like the reluctant podcaster. I don't really like. What am I doing here? I forgot what I even do on this show. I'm not. Like, I don't even know my own platform, and I don't record episodes. I just realized it's emails, right? I think. So I'll read another email. This is from Leo. It says, my name's Leo, and I'm a new M1. That means a new first-year medical student. And I just wanted to say thank you for introducing me to critical care and for inspiring me to hopefully pursue it in the future. Before starting school, I was working as a RC. What is an RC? I don't know what that is. Is that a respiratory therapist? I don't know what an RC is. In Palm Critical Care, and got to spend every day in the ICU. What I really loved most about it, and what confirmed the critical care, was the direction I wanted to go. It was the conversations I got to have with the patients and the families, and the social aspect of being a critical care physician. To be the person there for end-of-life conversations, among others, seems like an incredible privilege. I know it's been a long while since you posted anything, but if you do get back to it, I'd really love to hear your perspective and advice on the social side of critical care medicine and how you learn to approach these conversations. Thank you, Leo. Leo, thank you. I did a podcast. Here's an episode. I totally was attracted to critical care when I was a medical student and a resident because of the end-of-life discussions, and it absolutely is an incredible privilege. When I meet people and I tell them what I do, they're always like, that sounds really hard, end-of-life care. And of course it is, but when you do it, what you learn, it is a privilege, and it is incredibly rewarding. I love it. Okay, I love helping people pass away, and I love helping their families. I love it. I love that part of the job. It's not easy. Okay, it's not easy, but it is an absolute privilege to help people pass away and to be with them, and be with that patient and to help them pass away comfortably. It's beautiful. It's a beautiful thing. It's a different type of beauty. Okay, there's many beauties in life, and one of them is helping and being present with somebody as they die. Okay, that is a privilege. It's sacred. How I approach it, there's many ways to approach it, but I have some very practical advice for Leo. Okay, when you start out doing this, having these end-of-life care conferences and stuff, you might have some anxiety. You might be apprehensive about it. You might be dreading it, having the conversation. You probably have a script in your mind, like, okay, I'll start out saying this, maybe I'll say this. Sometimes there's like these mnemonics. Oh, just start a sentence saying, I wonder, and finish it. Or start off saying, I worry, and finish that, because you can usually come up with... So there's all these like tricks and stuff. There's nothing wrong with that. Okay, there's nothing wrong with having scripts in your mind and preparing in that way. I find it's probably a little more anxiety inducing. Here's the secret. Okay, you don't need to do all of that. You just go and talk to them like you talk to somebody, a friend visiting you at your house. You talk to them like a real person, okay? It doesn't need to be formal, it doesn't need to be sterile. You just talk to them like I'm talking right now on this podcast, or like I'm going to come home and talk to my wife later today. That's how you same tone, candid. You don't need to hedge. You don't need to be diplomatic. You don't need to have a political voice or whatever. Just be yourself. And talk to them. You don't need to prep anything. If you know what's going on with a patient, be honest about it. Like, if you're aware of the situation, you can talk about it just off the top of your head, And you can do that while being sympathetic. And here's the magic of that approach. For one thing, you don't need to go through this whole ritual of trying to prepare your mind or whatever. And also, the patients immediately recognize your authenticity and they trust you. That's it. That's the benefit. They trust you. They're like, oh, this person is being real with me. I can trust what they think. I can trust that they've done everything they can. I can trust them that we are at the end of my dad's life or whoever it is. I can trust them. And with that trust, they will feel so much better and have so much more comfort deciding to say goodbye to their loved one. Okay. So, Leo, that's my advice for you. Thanks for emailing. All right, let's switch gears. Okay, so I had some news. So I'm an author, right? My pen name is Wick Welker, Welker, Wick, Wick. I write sci-fi novels. I've written like 9 novels. One of my novels just won a huge competition. It's called Saint Elspeth, and it's a book about some aliens show up in the sky, and they don't do anything. these alien pods, right? And then they separate and they float and they land in every country and they don't do anything. They don't hatch and nobody knows why they're there. The world freaks out and one country bombs theirs and they say to another country, hey, if you don't bomb yours, we're going to bomb them for you. And that causes basically the apocalypse, a nuclear fallout from humanity's overreaction to the arrival of aliens, which honestly, not that unrealistic of a scenario. But anyway, and this book takes place 20 years later. And it's about a doctor who recolonizes San Francisco. She's the only physician in the colony. She has a rough life. She goes on a salvaging expedition. And so it's, post-apocalyptic. And what does she find floating in the bay in San Francisco? A dead alien. Nobody knows why they came. No one's ever seen them since. And now she has a dead body. And she used to be a pathologist. Now she has to do an autopsy. There it is. That's what the book is about. That's the starting of it. It's called St. Elspeth. It just won. It's called the Self-Published Competition of Sci-Fi, of Science Fiction, SPSFC. It was the 4th round of it out of 200 or 300 books. It won. It was number 1. It was the champion of my book. I couldn't believe it. I could not believe it. So it won the fourth iteration of that series. It's the sister series to Mark Lawrence's fantasy self-pub, which has produced a lot of great books. So such an honor and a privilege to do that. If you're interested in reading St. Elspeth, I will send you what is it called? The ebook for free. Just email me at icudrecmo@gmail.com. I'll just send it over to you. You can read it. You can purchase a hardback or paperback on Amazon, and there's also an audiobook on Audible with an amazing voice actress. She's incredible. She was too good for me. She was way too good for me. I can't believe I got her. She's amazing. Marie McCann. Incredible. So just check it out. So that's exciting news in my life. And it's also like, oh yeah, I guess I kind of can write books. What I'm writing right now, I'm finishing my sci-fi series called Dark Theory. I'm writing the 3rd and last book of that. It'll be out next year. And I'll give more updates about that as it comes along. I love it. What else I feel like I had something else to say. Oh, well, let's move on to books. Let's talk about books. So I haven't recorded an episode in a long time. And if you know me well, you know I read a lot. So I have a ton of books to talk about. So I have to be very selective here, but I'm probably going to talk about 3 or 4 books at least. So let's see. What do I want to talk about? All right, first book is called, I really enjoyed this book, and it's a crossroads of talking about medicine and diet and health. Okay, it's called Metabolical, The Lure and the Lies of Processed Food, Nutrition and Modern Medicine by Robert Lustig. Okay. So me and my wife made the switch about a year ago to entirely cutting out ultra-processed foods from our diets. I'm a busy father, and I'm a husband. But despite those things, me and my wife cook every day, and I bake several times a week. I bake sourdough bread. I bake lots of breads. I love baking, and I bake lots of treats and crackers and lots of stuff for my family. I stopped focusing on calorie counting to keep a healthy weight, which has worked for me throughout a lot of my life. And I instead focused on the food that's going into my body. So I made that kind of switch over a year ago. And it has made all the difference. I lost weight, and my relationship with food dramatically changed. hunger and satiety are toned down when you do this. And they're not as strongly associated with my like brain's reward system. Like that's been my own experience. So this book, it took little convincing to me to pick up this book called Metabolical. And here's the thrust of the book, the argument. Ultra-processed foods are causing fatty liver disease, metabolic syndrome, insulin resistance, mitochondrial oxidative stress, and chronic inflammation. Ultra-processed foods are slowly killing everyone. Okay, let's do a thought experiment. For 1 year, one person eats 3,000 calories of McDonald's food. Let's say it's a two twins, okay? So one twin eats 3,000 calories of McDonald's food. And they're stuck on an island. That's all they do, but all they have is McDonald's, okay? And they eat nothing but that. And they walk around the island, and then they do island things. So that same person's identical twin, let's say they're stuck on another island, where they can only consume 3,000 calories of coconuts and crab legs, okay? So 3,000 calories, 3,000 calories. Does anyone really in their right mind believe that these two twins will have the same weight at the end of that year? Do you believe that? Think about it. I don't think they will. Do you think, let's put the thought experiment to the next gear. Okay. Do you think, let's take one of those twins, compare them to McDonald's. Let's say the other twin only eats 3,000 calories of alcohol. Nothing but vodka, okay? And then let's assume they're supplemented with vitamins so they don't die from vitamin deficiency. Do you think that person eating just 3,000 calories of alcohol is not going to lose weight? You know there's something that's off, just with that thought experiment, in an intuitive way. And the author explains why in a cellular metabolic way. It is so much more complicated than calorie deficit. It's not about absolute calorie consumption. It's about the types of food or food-like substances you are putting in your body. That's what I think. Now, keep in mind, I'm not a dietitian. I'm not an endocrinologist. This is not my field of expertise, okay? I'm kind of a spectator here. One of the problems is high fructose corn syrup. It's not really a food. It's an additive to food to make food addictive. Okay, so let's back it up a little bit. Okay, this is a really important discussion. Tune in to what I'm saying because I really think this is very important what I'm talking about. Table sugar is a disaccharide called sucrose, which contains one molecule of glucose and one molecule of fructose. It is naturally found in sugarcane and fruit. It's also naturally very scarce. Every cell of your body can metabolize the glucose, no problem, through glycolysis to create energy, and it doesn't require oxygen to do this, okay? Fructose, on the other hand, is primarily metabolized by the liver. Something like 50 to 70% of all of the fructose just hits your liver. Sucrose is so incredibly sweet to us because we are engineered to crave it because it is a beautifully quick source of energy. Our cellular biology was not designed for a diet abundant in sucrose, okay? Here's the thing about high fructose corn syrup. It is also a mixture of glucose and fructose and doesn't even contain that much more fructose than sucrose. But the sugars in high fructose corn syrup are chemically unbound, as opposed to sucrose, the table sugar, which bonds glucose and fructose together. This unbound fructose from high fructose corn syrup hits the liver like a metabolic sledgehammer, as opposed to sucrose, which takes longer to metabolize and gets to the liver in a more balanced manner. High fructose corn syrup is also found in something like 75% of all foods in the grocery store. Why? Because it's sweet and addictive, and so the food makers make sure it's in their food. It's pervasive, cheap, and it's addictive. So high fructose corn syrup is both economically available and it's also highly bioavailable to your liver. All right, are you following me? Stay with me. Here's the problem. All the gut-punching amounts of fructose is killing your liver. Your liver is processing most of it, and here's the kicker. Unlike glucose, fructose enters the liver without the regulation of insulin. Insulin only controls glucose cellular uptake, not fructose. Fructose just waltzes into the liver and causes a very specific problem, hypermetabolic overload to the liver. It's just too much energy at once, and so your liver has to package it away somewhere. And what does it do? It stores it as liver fat in a process called de novo lipogenesis, or called DNL. DNL, de novo lipogenesis. DNL creates a toxic excess of palmitate, which is a saturated fatty acid which spills into the rest of the body, which is what dyslipidemia is. This also causes infiltration of fat into the liver, which is called steatosis, which is fatty liver disease. This process drives hepatic high insulin as a maladaptive attempt to keep glucose under control. The fat in the liver then drives the formation of other metabolites called DAGs or ceramides. Don't worry about that. That interferes with insulin receptor signaling within the liver cells. The liver then becomes insulin resistant. Because the liver becomes insulin resistant, what does it do? It starts dumping glucose into the rest of the body because it can't manage its glucose anymore, which then stimulates the pancreas to create more insulin, and boom, you have peripheral insulin resistance or type 2 diabetes. This right here is the epicenter of metabolic disease, and it all starts with slamming our livers with fructose. Okay, you following me? Okay, high insulin or hyperinsulinemia is bad. High serum insulin has an adverse reaction in every tissue bed of your body. High insulin can mess with satiety in the brain and increase risk for cognitive disease like Alzheimer's. High insulin messes with blood vessels and their smooth muscle, which can put you at risk for things like heart attacks and strokes. High insulin stimulates more triglyceride production, which can cause heart attacks and strokes. You can get diastolic dysfunction in the heart from high insulin. Fat tissue itself responds to insulin by what? Storing more fat. Skeletal muscle can get intramuscular lipid accumulation. High insulin can cause fluid retention and high blood pressure from the kidneys. The list goes on. Do you see how it's related? It's like a terrible metabolic chain reaction nightmare that all starts with ultra-processed foods. And this book will make it clear for you what I'm explaining to you. If a lot of that stuff was over your head, because I was fast with the information, it's not that it's like that complicated, but I was very quickly with that, this book will explain the things I'm just talking about. Western medicine is all about treating the symptoms of Western lifestyle. Okay? We focus on keeping glucose low in diabetics, which is a symptom of metabolic disease, rather than keeping insulin low by addressing the underlying metabolic disease caused by processed foods. Hospital revenue is derived from procedures, most of which are treating the end-of-line consequences of these metabolic diseases. Preventative medicine is not profitable. But do you know what is profitable? Catastrophic medicine. It's when the diseased bodies show up that the coffers are open. So, I'm a doctor, I'm an intensivist, anesthesiologist. I don't think Western medicine has done this by design from the beginning. Western medicine is simply a guild of highly educated people that are working within a market-based institution that follows money. And the money is found in treating the symptoms of metabolic diseases, not treating the underlying causes or the preventative causes. Obesity is a symptom, not a disease. I've said that many times. I never know if I'm right or not because I'm not an expert, and sometimes I get hate for it. But obesity is a consequence of metabolic disease. And this author, who I forgot to mention, the author is an endocrinologist. He agrees. Something like 20% of obese people don't have metabolic disease, and plenty of healthy people, everybody thinks they do. Let's reiterate, you can be obese and healthy. I have been saying this for years, but I don't have the endocrinology chops to back me up, and now I do, because he's an endocrinologist. Don't people see that by labeling obesity as a disease, it opens the pharmaceutical floodgates to profit from yet another symptom of metabolic disease without addressing the underlying cause, which is ultra-processed foods? So don't get me wrong. I'm all about fat positivity, and I do not believe that obesity is a moral failing. Obesity is a fallout from conspiring corporate influences to keep us addicted to harmful food products. Fortunately, the new popularity of GLP-1 drugs like Ozempic do address the underlying metabolic derangements, much like addressing high glucose with insulin. It doesn't really address the problem of intake of ultra-processed foods. It's not like GLP-1 drugs are going to stop people from magically ingesting toxic food, and they keep people reliant on an expensive pharmaceutical. Are you getting the theme here? It's profit. But it's even worse. This arrangement with insulin and GLP-1 dependence creates a rent-seeking operation of people's very bodies, where the food industry creates the persistent metabolic disease and the big pharma industry mitigates the fallout from the metabolic disease. It's perverse. It really is disgusting. The real solution is cessation of ultra-processed foods, which simply fix the metabolic disease. But here's the thing. The processed food market wants you to believe it's all about the calorie deficit. So how many people believe it's all about calorie in, calorie out? You probably do, right? Probably 90% of my audience probably believes that. They want you to believe that so that obesity and metabolic disease will remain a moral failing of the consumer, As long as it's your fault and not theirs, no policy change is needed from the FDA or the USDA. Okay? I feel it in my bones that what I'm saying is correct. So let's just discuss the gut real quick. The gut needs fiber. Why? Because there are billions of bacteria down there, and they directly touch the skin of your gut. If they directly touch it, you're going to get inflammatory cells coming in to keep the bacteria in check. A fiber lining protects, like a mucosal lining protects the gut lining, and it feeds the bacteria appropriately so they don't have unchecked growth. Well, ultra-processed foods have detergents in them, also known as emulsifiers, that break down this fiber mucus layer, and which exposes your gut to that bacteria, which causes chronic inflammation. Stuff like soy lecithin, polysorbates, carboxymethylcellulose, propylene glycol, datum, xanthan gum, many more emulsifying foods. They bring water and fat soluble things together, right? They're put in foods to make foods smoother and have a more smoother and tasty quality. That's why they're in there. But all of these things are literally detergents. They disrupt that gut mucosal barrier, and they cause inflammation and translocation of bacteria and their products like lipopolysaccharides. This is the concept behind the leaky gut theory, right? Leaky gut, if you've heard that. That is not a formal diagnosis, okay? That's not like an actual, it's like a theory. Leaky gut, just to be, is a term that's been co-opted by a lot of pseudoscience hacks to try to sell you stuff. Okay, so this author is not a pseudoscience hack. I am not a pseudoscience hack, but this is the concept behind leaky gut, right? It's like an emerging concept, but it's not a formal diagnosis. So, anyway, the spoiler about this is this leaky gut syndrome and chronic inflammation can also drive metabolic disease via hyperinsulin and oxidative stress, which is where too many oxygen-free radicals are created for too many cellular calories, and they have a tendency to tear apart your cells. That's what oxidative stress is. It's too much oxygen created from too much energy from food. Okay, so are you seeing that there is no shortage of mechanisms by which ultra-processed foods destroys your body? I've only gone over like 3 of them. The book goes over many more, okay? But I'll stop boring you because I'm being quite loquacious here. So are you feeling trapped, right? Do you feel trapped thinking about processed foods and what to eat, what you can do? I'll tell you what I do, what me and my wife do. One criticism I've read about this book is that the author isn't specific about what real food is, because he's always saying, eat real food. My response to that is stop playing dumb. You know exactly what real food is. If you really don't know, there is a food processing grade created in Brazil called Nova, okay? And there's Nova groups of processed foods. There's 1, 2, 3, and 4. This is great, okay? Let me just go over it. Nova 1 are unprocessed or minimally processed foods, like fruits and vegetables, eggs, milk, plain meat, rice, okay? Nova 1. Nova 2 are processed culinary ingredients, so substances extracted from group 1 or foods or nature, so like sugar, oil, butter, salt, honey, starch. Nova group 3 are processed foods made by combining groups 1 and 2, and they generally have 2 to 3 ingredients like canned vegetables, cheeses, fresh bread, like that I bake at home. Homemade bread is a group 3 processed food. Group 4 are ultra-processed foods, industrial formulations with additives, flavorings, emulsifiers with little resemblance to whole foods, so like soft drinks, chips, fast food, instant noodles, packaged snacks. You know what they are. Here's my advice, and here's what I do, and my wife does. Never eat group 4 foods, ever. Just be done with them. You don't even really like them. You don't. In my home, the only group 3 processed foods in our pantry are like pasta, beans, bottled tomatoes, oatmeal. In our fridge, it's mostly group 1 and 2 with some 3, so like milk, cheese, butter, fresh veggies, condiments. Everything else we cook and we bake. The only other major group 3 processed food in our home is bread and other baked goods that we bake and process ourselves. So most of the processed food in the house is me and my wife have processed it. Do you want ice cream? Buy an ice cream maker. That takes only 4 ingredients to make vanilla ice cream. I do that all the time. Does this take time and planning? Of course. Does it take money to do what I'm trying to talk about? Yes, it does. It takes upfront kitchen and pantry infrastructure costs, but it will be way cheaper in the long run as your grocery bill plummets. Me and my wife, after doing this, we spend way less on groceries now. So it's like, oh yeah, you can buy an ice cream maker, but that's expensive. Like you will literally, do you know how much money you will save if you do this? If you stop buying processed foods? It is not only that, it is joyful to make your own foods and feed them to your family, knowing that you're not giving them what are literally poisons. Will you lose weight and reverse your metabolic disease? Absolutely, you will lose weight. Can anyone do this? Yes. Is it easy? No, not at first, but once you adjust, there's no going back. All right, so I recommend that book. It's called Metabolical. It's amazing. It's amazing. Metabolical by Robert Lustig, Lustig. Okay, I have so many more books I want to talk about, but I should probably limit it. Let me look at my list. All right, let's do some history. The next book is called The Glorious Cause: The American Revolution from 1763 to 1789. This is by Robert Middlekauff. It's part of the Oxford History of the United States series. It's one of the reasons I picked it up. I'll be brief with this book. I don't know what it was about this book. It's either I found the history presented in it was presented in a boring manner, or that I just think I need to be honest, that I find the American Revolution kind of boring. I think it's both. This book spent like a third of the time talking about the Stamp Act and its ramifications on galvanizing the American people toward war. I'm not saying the Stamp Act and the Townsend and Sugar Acts weren't all extremely operative in what happened, but I do not know why the author spent so much time on those things in a really disjointed narrative. It was killing me. So this book didn't really gel with me very well. But I just kind of want to cut to the chase of why I want to talk about this book and the American Revolution. I cannot tell you how little I sympathize with a bunch of rich people complaining about paying taxes. I have zero sympathy for rich people and their tax burden. Zero. And okay, perhaps it's a little bit too reductive with an unfair modern lens for the American Revolution, but that's really what it boiled down to. It was rich people complaining about taxes. I just don't really sympathize with their cause. If I'm being honest, I don't. I truly don't. I don't really sympathize with the cause of the American Revolution. Now, I don't want to minimize what was achieved during and after the war. Okay, it was incredible what was achieved. The shedding the shackles of a monarchy and drafting a constitution with a parliament and a guaranteed list of civil freedoms, that was incredible. Okay, people weren't throwing off the shackles of monarchies till well into the 1800s. The Americans did it really early for Europe. And the technological breakthrough of the Constitution with the three branches of government designed to reduce power concentration was an astounding achievement. So I don't want to minimize that, because it was. But here's the real question, okay? I really want you to think about this question. Okay, you ready? Did the material conditions and freedoms change for the average American after the Revolutionary War and the drafting of a new government? No, they didn't. Not at all. They didn't. For the average American, the material conditions didn't change. Now, one could argue, yeah, well, it opened up the pathway for those civil freedoms and abolition to be realized. That argument would hold water if those exact things didn't also happen in all the other Western countries, including Great Britain. Either before they did in Great Britain, those things happened before they did in the U.S. or at roughly the same time. Slavery ended in Great Britain way before it did in the U.S. and without a civil war. So the American Revolution was a revolution of the sitting aristocracy of slavers. They waged a war because they didn't like the king's taxes. They used the bodies of the underclass as fodder, as well as keen strategy by really great leaders like George Washington. They achieved an independent government with the incredible act of shedding itself of monarchy, and then nothing changed for anyone else who lived in America. That's the truth, okay? And in fact, things got considerably worse for Native Americans and black people. The real revolution that changed the lower class was the Industrial Revolution about 50 years later. Those really are kind of the facts, and that's why I find the American Revolution, both boring and not something that I get that excited about. That's why I read the book. I kind of wanted to get excited about it, but it made me less excited. I know a lot about I know tons of Americans buy into the lore that the founders and framers were inspired by God and that America is now some divine global instrument. Well, that is propagandized nonsense, and I say that as an American Christian. All right, I'm gonna do two more books. All right, it's been a while since I've done this, and so you get a double feature or whatever. All right, next book is called "The Origins of Political Order: From Pre-Human Times to the French Revolution" by American economist Francis Fukuyama. This was written in like in the in 2000s, I think, or 2012 or something. Okay, so this book. Okay, let me just if you get two people in a room, you have politics. Just wherever two people are found, that's where politics are found. By sheer virtue of the fact that someone's thoughts are only contained inside their skulls, and they can present themselves in ways that are not reflective of those true thoughts, everyone is a politician to a certain degree. Fukuyama has several main themes with this book. And the chief is, it's a challenge. I mean, this book is basically about, I mean, it's in the title, it's the origins of political order. How do we get our political order that we have today? And he kind of tracks it through history. His chief, he challenges the dichotomy between Rousseau and Hobbes. That's a lot with this book, and I'll get more into that. Humans never existed in a separate and childlike state when they were, archaic prehistoric humans, in which they didn't socialize. They were never like that. And it was never like Hobbes, where there was it's always been the zero-sum state of violence with zero social order, which is more Hobbesian. There wasn't some point along cultural evolution where humans threw up their hands and were like, okay, fine, we need to start cooperating with one another. Let's form a society now. That never happened. There was no demarcation. Fukuyama argues that political and social orders have always existed side by side with human beings from the very beginning of human beings. Our brains are designed for socialization and highly evolved to negotiate language and nonverbal cues for one another. Rousseau and Hobbes assumed that primitive people started as individuals and then cooperated out of naked self-interest. But this cannot be true. Humans have always been social and they've always been political. This was a fantastic book. Fukuyama tries to nail down when it was that we start to see modern political order form in human history. One thing he makes really clear, there isn't some chain of predictable sequences that human society goes through from band to chiefdoms and then a modern state. There's nothing like that. Karl Marx had that wrong. Social progression is as a conceit of academics when they think there's this natural social evolution. Human societies have existed along these arrangements for quite some time already. What could easily be considered a modern bureaucratic state existed in BC China long before it came into existence in the West. They had a huge state. There does seem, however, to be a transitory point between these different arrangements that seems to be where kin selection and reciprocal altruism as the underpinnings of political order switches to a centralized and more centralized state, right? You have this demarcation, kin selection, reciprocal altruism, where you favor your kinfolk, and then that switches to a centralized bureaucratic state. The challenge is switching allegiance from kin to state that he gets into with a lot of more ancient cultures. Once a centralized state is formed, it requires two ingredients to function: a rule of law and accountability. If these two things are not maintained and degenerate into loyal patrimonialism, or which is basically nepotism, then the state will begin political decay. Political decay also happens when the state institutions do not change or reflect the changes in society. Religion is a highly critical source of social cohesion that helps create the state, and he talks about that a lot. The state and its institutions, tied together with the connective tissue of religion, are highly conservative by nature and become brittle and resistant to change. That's what a lot of, I think, modern conservative people don't understand, is that the government they rail against is actually extremely conservative, right? Anarchism, which is more of a leftist principle, is extremely left, right? Anarchism is no centralized state. If you have a centralized state, that's almost by definition conservative. I won't get into that, but conservative people don't understand that. If all you're consuming are talking head pundits and stuff, you don't understand the things I'm talking about. If a society is weak and degenerates into a vassal for rent-seeking elites, then it also experiences political decay. China had a state long before Europe, and Europe, in fact, has never had a central government like China ever had. That's probably because China has more cultural homogeneity. The caste system in India hampered social mobility and literacy, unlike in China, and this made their state and military weak, but it persisted because of a strong society ruled by caste and patrimony. The consequence of China having a stronger state while India has a weaker one is that China lends more to authoritarianism, while India is constantly hampered by its weak state, but supported by strong and fragmented social groups who act as a countervailing force. In Europe, kinship mattered more to aristocrats and less to the peasants, which was way different from Eastern cultures. Kinship was abandoned sooner in Europe, and individualism started to occur. way more in Europe than in East Asia. The agent behind this conversion was the Catholic Church and Christianity. The Fukuyama argues at this point. There was a contractual understanding and underpinning between the lords and families, even between children and parents. This contractual way of life easily led to a more market-based society. Because kinship was so much weaker in European societies, individuals needed protection from stronger aristocrats, hence the formation of serfdoms in Europe, which was uniquely a more European phenomenon. The Catholic Church prohibited cross-cousin marriages, which was not prohibited in a lot of Eastern cultures. They prohibited marriage of kin to dead widows, adoption of children, and divorce. They prohibited all those things. They also promoted celibacy, right, within their ranks. All of this contributed to the destruction of kin-based societies. To me, that was a big revelation. When the state and religion merge, then you have a fragmented market-based society based on individuals and patrimonialism among the elite. This is the same social arrangement that still exists in the West today, right? It's not really, and he argues this point, and I think he argues it well. It's not really that capitalism fragmented society. It's more that capitalism more easily grew out of a fragmented society born from the monolith of the church and the state. There's a lot more to say about this book, but I'm not going to bore anymore. If you're interested in what I talked about, check it out. It's called, what is it called? The Origins of Political Order by Fukuyama. Okay, one more book. And you know what it is? It's fiction. And you know what it is? It's The Stand by Stephen King. Okay, so I had COVID about a couple months ago. It was my first time getting it, actually. And I got it at work, and my family, my wife and I, we had a newborn. We wanted to protect them, and nobody got COVID, but I sequestered myself in the basement for like a week while my wife did all the childcare. It was kind of a nightmare for her and for me. But anyway, I started reading The Stand when I was like sequestered. I read The Stand when I was a teenager, and I loved it. And I also watched the 1994 miniseries multiple times when I was a teenager. I loved that also. Now, I reread it, the uncut version, and I gotta say, I love it even more. And I appreciate the story in new ways. This book is officially one of my favorite books of all time. And if I had to boil down why it's so good, it's because of the engrossing characters, their arcs, their individual and communal struggle with good and evil, and the incredibly nuanced way that evil is thwarted. The epic and blunt theme of good versus evil in this book was masterfully achieved. This book stoked all of my emotions, and I deeply cared for the characters. So I'm going to talk about it a little bit more. It's totally spoilers. Lots of spoilers, okay? Don't listen more. And basically the podcast is over after this. So you can just say goodbye if you don't want to listen to more. But if you want to geek out with me about this book, listen to more, okay? And then we're done anyway. Okay, so let's start with the premise. It's compelling from page 1. The first third of the book is a pandemic killing off 99.9% of human life. And the tale focuses on those that will survive into a new and uncertain world. All of this is told with an edge of mysticism represented by the beneficent Mother Abigail and the obvious demon guy, Randall Flagg. Each main character's backstory is interesting right from the beginning. You got Larry Underwood, the flawed and drug-crazed musician. Stu Redmond, the quiet, reserved, level-headed Texan. Fran, who's pregnant and, kind of immature young woman. Nick, the deaf and mute traveler with a good soul. You got Tom Cullen, the developmentally delayed young man. And Harold, the awkward and bullied teenager. And then let's not forget Lloyd Henry and the trash can man. Each scene explaining their backstory is just so compelling, all told while people around these characters are, dying. The book then transitions to Act 2, where all the characters are summoned to Boulder by Mother Abigail, or the walking dude to Vegas through their dreams. The transition of each of these characters from their former lives to the post-apocalyptic landscape is exceptionally handled. Okay, I want to focus on Larry Underwood. This is a guy he was, a rising famous musician. He blows all of his money on parties and drugs and ends up back at his mom's house before the pandemic hits. His mom thinks he's a loser, and Larry is clearly a flawed character right from the beginning. The way he transitions to one of 4 men who basically walk into Mordor to face Randall Flagg because a dying prophetess told him to do it is so inspiring. Larry shows us that circumstances can change us and that we can rise to the occasion and be brave in spite of our past mistakes and current flaws. So I loved him. Larry is never perfect, but he is able to focus on what's important, and his ego shrivels away from that process. The virtue and integrity of Larry, Glenn, Stu, and Ralph as they walk to certain death in Vegas is something I'll never forget. I loved it. They go because of faith and fear and courage, and it is an awesome experience to read their journey. Nick is a saint from the beginning to end and doesn't actually have much of a character arc because he's just good through and through. He's like, the Rock. His death at the hand of Harold served to condemn the evilness of Harold's actions. Harold is one of the most important characters in the book. Like Larry, he starts with fatal flaws. He's pugnacious and arrogant and feels entitled to Fran's love after everyone dies. He's also clever, he's smart, he's brave. Harold has so many moments of introspection and ample time to stop the path he eventually takes. Harold's hate for Stu for taking Fran from him was too much. He couldn't handle it. He let that hate consume him, and then Randall Flagg co-opted that hate and used Harold for his purposes. The reader is taken down the incremental steps and pathology of Harold that ultimately leads to him bombing and killing Nick and the others. It's so tragic and so sad. It was such a low point of the book, seeing how much hate can lead to such pointless violence and the stupidity of that violence. And then I really loved Harold's ending. He escapes with Nadine, the evil bride-to-be, to Randall Flagg, and his motorcycle peels out on an oil slick. He crashes and he breaks his leg. And then Nadine abandons him and Flagg abandons him. He just dies alone and fully aware of his choices. And that's one of the most important themes in this book is choice. Everyone in the book makes choices of their own free will. Some choose to go with Mother Abigail, others choose Randall Flagg. And then Tom Cullen might be the crux of the whole work. One great observation from the book is when Tom goes as a spy to Vegas. He notes how the people in Vegas that follow Flagg don't seem to be bad people, really. This is a quote from the book. They were nice enough people and all, but there wasn't much love in them because they were too busy being afraid. Love didn't grow very well in a place where there was only fear, just as plants didn't grow very well in a place where it was always dark. Tom notices that they just seem to be afraid. Are the people in Boulder with Mother Abigail afraid also? Yes. So what's the difference? And I've thought about it a lot with this book. And I think the difference is one type of person avoids and outsources their fear to a strong man, and the other faces their fears. I think it's cowardice versus courage. Everyone is afraid, but it's what you do with that fear that makes the difference. The spies from Boulder, Tom, the judge, and Dana, they're all terrified of Flagg. But what do they do with that fear? They trust Mother Abigail and they go and face those fears. Stu, Glenn, Larry, Ralph are absolutely terrified every step of the way to Vegas. And they are courageous because of their fear. While all the people in Vegas may be regular, good people, they have ceded their fear and their agency to an evil demon. And that makes them evil demon followers, regardless of how nice they seem. So they are very complicit, just as much as Harold and Nadine are. Although I did love the mild redemptive arc of Nadine, who throws herself off the hotel after being impregnated by Flagg. The ability to choose is one of the most important themes in the book. Every character in this book is forced to make active choices, and the result of those choices are what make the difference. The only exception to this is probably the trash can man, who is a victim of his own very severe psychopathy that Flagg exploits to his own undoing. Right. So let's talk about the ending. Some people didn't like the ending of The Stand. I loved it, and I want to explain why. Was there a big showdown between Flagg and the Boulder Free Zone people? No, there was not. That would have been the cliche Hollywood ending that many readers probably wanted and were disappointed that they didn't get. What happens is 3 guys stroll into Las Vegas with nothing but their clothes on their backs. They surrendered and were quietly arrested. One of the most important scenes in the book is when Randall Flagg confronts Glenn from the Boulder Free Zone in a prison cell. Flagg offers to let him go if Glenn will simply get on his knees. Glenn's response encapsulates the point of the entire book. Okay, so Flagg says, "Hey, I'll let you go if you just get on your knees." And here's Glenn's response: "Oh, you're a card. I will tell you what you do. Why don't you find a nice big sand pile, get yourself a hammer, and pound all the sand right up your ass?" That's his response. Glenn says no. Larry and Ralph said no. And that's all it took. No fighting, no battles, no weapons, just dissent. And that is the stand. Here's Flagg's thoughts while contemplating the fact that there are spies in his midst. Okay, here's his thoughts. Why did he have the steady gnawing feeling that Tom Cullen must be found and killed before he could leave the West? Because it's what I want, and I'm going to have what I want, and that is the reason enough. Spies from the Boulder Free Zone were sent not for reconnaissance, but simply as a dissenting force. The dissent is what matters. Strong men cannot tolerate dissent. They cannot tolerate diversity, heterogeneity in any way. They must have a submissive monoculture that they control. Dissent breaks strong men. It breaks dictators, fascists, and authoritarians. Their initial strength, which is intolerance of the dissent, becomes their undoing. A voiceless and afraid populace is weak and incompetent. Dissent drives them mad, just like it did in this book. The fact that there were dissenters completely distracts and derails Flagg, and everything goes downhill for him. He cannot summon his forces to stop the shenanigans of the trash can man, if you recall. The all-seeing eye of Flagg is so distracted he didn't even notice trash can brought a literal atomic bomb to his doorstep. And what happened in that scene? One of his own decries the torturing of Larry and Ralph, and so Flagg burns him to the ground with a ball of fire, which goes out of control and ignites the A-bomb, and it nukes all of Vegas. The battle is over before it even starts. So the quote, the hand of God here is simply Flagg's own wrath backfiring and destroying him and his followers. And that is the stand, and that is why I love the book. It's simply speaking up when you're afraid and when no one else will. It isn't violence, it's dissent. And timely dissent is both rare and powerful. Okay, let me repeat that. Timely dissent is both rare and powerful. I love this quote from the end of the book. The place where you made your stand never mattered, only that you were there and still on your feet. What an incredible lesson to be learned about nonviolent resistance. This is one of the best books I've ever read in my life. My heart broke for every character. They are with me forever. I love everything about this book. If you have not read The Stand, read it. I loved it. All right. That's it for me. Thanks for joining in again. I have no idea when I'll make another podcast, but this reminded me that I do enjoy this. It is fun. I do like to talk about whatever. So hopefully I'll get another episode up soon. Email me at icudrecmo@gmail.com about anything. And anyway, I'll see you next time. Thanks.